Good evening, everyone. So today we are going to discuss an important topic, that is early diagnosis and the treatment of patients with chronic kidney disease having type 2 diabetes. Let's start with this case. Mr. Raj, who is a 57-year-old man suffering from type 2 diabetes. His HbA1c and blood pressure, those are relatively well controlled, but his physician is concerned about his kidney health. So aside from the usual ailments, I feel good and I hope to stay like this for many years to come. So this is the comment from Mr. Raj, and we need to respect this wish as a physician. So this 57-year-old man diagnosed with type 2 diabetes for last 10 years, HbA1c 7.4%, not that bad, with standard of care for glycemic control. Office BP 138 by 84 millimeter of mercury. So these two number, I think most of us not that satisfied. That means HbA1c 7.4% need to be a little bit tighter control we need, especially when we have certain drugs in our armamentarium, which does not have hypoglycemic side effects much. For an example, SGLT2 inhibitors or GLP-1 RS, we can achieve that sweet spot in the HbA1c target. We can reach 6.5, less than 6.5% too. Obviously, if we use sulfonylurea, we need to be extra cautious because already 10 years of diabetes and there is 57-year-old. So we need to be cautious if we are using sulfonylurea, otherwise, or insulin. Otherwise, if we can make this control with GLP-1 RA or SGLT2 inhibitors, and we can reach less than 6.5%. So nothing like that. And target BP, again, 138 by 84, I think we are also not happy. At least we need to reach that less than 138 millimeter of mercury, that number, especially if it is not, we need to use up-titrate the dose of certain antihypertensive agents. So if we go by the number, these numbers are really scary as we are sitting in the epicenter of the diabetes tsunami of the world, that is India, which is a world capital of diabetes. Braj is one of the 74 million adults across India with type 2 diabetes. And when we talk about chronic kidney disease, again, chronic kidney disease in type 2 diabetes that has a high disease burden in India. So when we talk about chronic kidney disease, there is an estimated of around 35 million adults had chronic kidney disease and type 2 diabetes. So 48% prevalence of chronic kidney disease in type 2D patient across the population in India. So yes, he is one of the 74 million adults across India who are suffering from type 2 diabetes. But there is a possibility that he could be one of those 35 million with CKD and type 2 diabetes too. If we go by the eGFR value, his eGFR is coming between 60 to 89. So we can say it belongs to the G2 category. So again, we can mention it is a mild CKD, which is based on the eGFR. But if we go by the data, even from the Western world, this is an ADD CKD study where it was found that 85% patients had eGFR assessed during the last 15 months prior to the study participation. So there is 15% of the population even not even measured the eGFR value. And very unfortunately, only 47% of them had urinary albumin-creatinine ratio assessment. So that is really scary. So this is the data from CKD patients who are having diabetes. The number was 5,036 patients. So CKD is underdiagnosed in patients with type 2 diabetes. And why? Due to underutilization of recommended screening of chronic kidney disease. So why we need to screen them? Because if the diagnosis is late and CKD progression there, that is associated with type 2 diabetes burden, both on the patient burden, and healthcare system burden. From the perspective of the patient, what will happen if there is CKD that is associated with type 2 diabetes compared to alone type 2 diabetes? That means only type 2 diabetes is there without CKD. With CKD, the 2 times increased chance of myocardial infarction, 5 times increased chance of heart failure cases, 3 to 6 times greater risk of hospitalization due to heart failure, and 3 times more chance of cardiovascular deaths. And if we talk about burden on healthcare system, the type 2 diabetes and moderately to severely increased albuminuria versus type 2 diabetes and normal albuminuria, those type 2 diabetic patients who has moderately to severely increased albuminuria, they have higher rate of emergency room services, 2 to 4% increase, 4 to 10% higher rates of inpatient admissions, 4 to 40 times higher rates of receiving dialysis. So that is why we need to pick up those cases early, so that early intervention may help to reduce to the downstream cardiorenal risk. Now, in this case, in this typical type 2 diabetes patient, where we had the number of eGFR, the value of eGFR, the risk of CKD progression is underestimated. Because here, if we say that eGFR is 61, so it comes around G2, so mild, and we cannot predict the higher risk. What happens if we have the data of urine albumin-creatinine ratio? In this particular patient, it was 852. So there is macroalbuminuria. So it comes under the A3 category. So G2, A3. This is why we need to go for urine albumin-creatinine ratio testing. There is no doubt in that. And based on this patient's eGFR and urine albumin-creatinine ratio, the guidelines recommend he should be screened more often, or at least twice annually. Again, when we talk about albuminuria, we need to understand the albuminuria is an early predictor of heart and kidney disease outcomes. So when we talk about these lines, 3 lines, The first green line, which is showing urine albumin creatinine ratio less than 150, those patients. The deep blue line between 150 to 300 and light blue line more than 300. Interestingly, if we go by the 6 months duration, there is a gap. So from very early, even around 6 months, the CV events are more common in those group who is having urine albumin creatinine ratio more than 150. And it is going high with passing months. So composite CV outcomes, it could be myocardial infarction, stroke, first hospitalization due to heart failure or unstable angina, coronary or peripheral revascularization, and a very hard endpoint, that is cardiovascular death. We can see the very early dissociation. And that is why if we have higher albumin creatinine ratio, we will have more cardiovascular bad outcome. Even the kidney outcomes, if we go by that 12 months cutoff, 12 months time, with increase in urine albumin creatinine ratio, there will be more happening of kidney composite outcome. It could be first doubling of serum creatinine, end-stage kidney disease, or death. And that is why the professional bodies had recommendation, especially the European Society of Cardiology. They're giving clear-cut recommendation for patients with CKD and diabetes. It is recommended all diabetes patients should be routinely screened for kidney disease, not only by assessing eGFR, but also we need to calculate, we need to check the urine albumin creatinine ratio. So eGFR, calculation by CKD PI formula, and urine albumin creatinine ratio. These two were recommended for all patients who are suffering from diabetes. And this guidelines recommend both eGFR and urine albumin creatinine ratio. Testing should be done annually for all patients suffering from type 2 diabetes. eGFR generally measures the kidney function, and urine albumin creatinine ratio, they are giving us about the idea about the kidney damage. It measures kidney damage. So at least yearly, we need to do these two: eGFR calculation and urine albumin creatinine ratio estimation. So professional bodies like ADA, KDIGO, ACE, they recommend using both eGFR and urine albumin creatinine ratio to properly identify, stage, and monitor CKD in patients with type 2 diabetes, as eGFR alone may miss the earlier stages of chronic kidney disease. Support routine eGFR and albuminuria screening to assess early cardiovascular disease risk in patients with CKD associated with type 2 diabetes. And when we talk about urine albumin creatinine ratio, it is an important and easy measure of kidney health. Few important practical points. First of all, the ADA, they has approved using urine dipstick or a urine sample to calculate urine albumin creatinine ratio. What is required? 2 to 3 positive tests. So one positive test is not enough. 2 to 3 positive tests are required within a span of 3 to 6 months period before confirming the diagnosis of moderate or severe albuminuria. The 24-hour urine collection, 24-hour urine protein estimation, that does not improve accuracy and is not recommended. So random spot urine collection is recommended. Few important points, like within 24-hour exercise, presence of infection, fever, congestive heart failure, marked hyperglycemia, menstruation, and marked hypertension may elevate urine albumin-creatinine ratio independently of kidney damage. So that may create a false positive results. So we need to understand these important issues while interpreting the results. Now, when we talk about chronic kidney disease and cardiovascular disease progression in type 2 diabetes, this is actually driven by a combined effect of metabolic, hemodynamic, and inflammatory with some fibrotic factors. So, drivers of chronic kidney disease and cardiovascular disease in type 2 diabetes progression, if we can say, the number one, hemodynamic, number two, inflammation and fibrosis, and number three is the metabolic. So, all these factors ultimately lead to affect kidney, affect heart. So in kidney, it will produce tubulointerstitial damage, inflammatory changes, glomerulosclerosis, mesangial expansion, glomerular hypertrophy. In heart, it will produce myocardial fibrosis, atherosclerosis, vascular stiffness and calcification, ventricular hypertrophy. Both of them together ultimately will lead to kidney fibrosis or cardiac fibrosis, and CKD will be progressed with cardiovascular disease progression. So these three we need to understand. Yes, we have RAS blockade. We have SGLT2 inhibitors. But the patients with type 2 diabetes and chronic kidney disease, they are at higher risk of chronic kidney disease progression. If we go by the data of a renal trial, there is definitely improvement in the losartan arm, but there is a good amount of residual risk that we can see here. So even after hemodynamic control with losartan, there is a persistent residual risk. So almost around 50% residual risk is there. When we talk about credence, on top of a C inhibitor or ARB, we got one SGLT2 inhibitor, canagliflozin. But at the same time, yes, there is a 30% relative risk reduction favoring canagliflozin over placebo. But even with canagliflozin, the residual risk is almost 15%. Now coming to DAPA-CKD. Again, DAPA-CKD is a very, we know that a landmark trial. We got something in type 2 diabetes management or CKD management that actually translating into a robust reduction of outcomes like sustained more than 50% eGFR decline or end-stage kidney disease or kidney-related death. There is a 36% relative risk reduction favoring dapagliflozin compared to placebo. But again, the residual risk was 10%. The EMPA kidney data, even with relative risk reduction favoring empagliflozin by around 28%, but at the same time, it has more than or around 15% residual risk, that is persistent risk. So with canagliflozin, dapagliflozin, and empagliflozin, the triad of which has two important terms like hemodynamic arm and metabolic arm, these two arms can be addressed with both canagliflozin, dapagliflozin, or empagliflozin. But at the same time, we can see there is a persistence of residual risk. With hemodynamic control by losartan, the residual risk was almost 50%. But adding SGLT2 inhibitors, it was dropped down, but still the risk is there. And that is why the another part, inflammation and fibrosis part, which come into the mind of the scientist, the clinical researcher. And the mineralocorticoid receptor overactivation in type 2 diabetes, that is one of the major factors which contribute to CKD progression. So if we talk about different issues like ACE inhibitors and ARBs, they are addressing that hemodynamic part. They address the elevated blood pressure and intraglomerular pressure issues. Apart from ACE inhibitor ARBs, we can consider thiazide-like diuretics, dihydropyridine, calcium channel blockers, SGLT2 inhibitors, which address that hemodynamic part. The metabolic part, that means the poor glycemic control issues, that can be addressed by different glucose-lowering agents like SGLT2 inhibitors, GLP-1RAs, metformin, and some other anti-hyperglycemic agents. But the inflammation and fibrosis part, that is the primary target of the mineralocorticoid receptor antagonist. This mineralocorticoid receptor antagonist not only address the inflammation and fibrosis part, but also they had an ameliorating effect on hemodynamic atrocities. And that is why Finerenone, the newer mineralocorticoid receptor antagonist, is something new which targets mineralocorticoid receptor overactivation and slows heart and kidney disease progressions in patients with type 2 diabetes. So this is the molecule of Finerenone, which can block the mineralocorticoid receptor. So mineralocorticoid receptor overactivation can be blocked along with hemostatic action, and we can address, if we can address the issues like hyperglycemia, high salt load, and oxidative load, which are actually playing a critical role on this mineralocorticoid receptor overactivation. So if we block that with Finerenone, then we can address the inflammation and fibrosis part and hemodynamic factors part with this molecule. Apart from that, yes, obviously we need to take care of the metabolic factors. So ultimately we will have heart and kidney protection. So is there anything new in this mineralocorticoid receptor antagonist, the Finerenone? So if we talk about Finerenone and other steroidal mineralocorticoid receptor antagonists, they have some distinct differences in their pharmacophore, the chemical structures, modes of binding, and that ultimately lead to differences in downstream effects. So it is, we can see, this is Finerenone, which is a bulky, non-steroidal, selective mineralocorticoid receptor antagonist. But they are not non-steroidal, they are steroidal. So they are not that selective like Finerenone. So structural properties, they are spironolactone and eplerenone, they are flat, they are steroidal, whereas Finerenone is bulky, non-steroidal. And if we talk about the potency of Finerenone, yes, they are comparable with spironolactone, but more potency compared to eplerenone. And selectivity is very high. So they are, the Finerenone are highly selective to mineralocorticoid receptors, and it showed lesser risk of breast-related side effects. We know the side effects of spironolactone producing gynecomastia in male, and that is why it is many times we are not using this molecule spironolactone in male patient. In that case, we use eplerenone there because we can see the selectivity of the mineralocorticoid receptor is more in eplerenone compared to spironolactone. But again, if we see the potency is less in eplerenone compared to finerenone and spironolactone. And that is why if we talk about both the side effect and the efficacy, the finerenone is something which has high potency. At the same time, they are very much selective to mineralocorticoid receptors. So the side effects are less. The CNS penetration, again, with finerenone, it is less. It is almost zero. It is having no anti-androgenic side effects, as we had mentioned, which are common with spironolactone and sometimes with eplerenone, that they are not there with finerenone. The half-life is 2 to 30 years, 2 to 3 hours. This shorter half-life and no metabolites. So if there is active metabolite, again, there is a higher chance of hyperkalemia. But as it has very short half-life and no metabolite, so ultimately there is low rates of hyperkalemia. We know that in spironolactone, they has active metabolites, and that is one of the major reason why spironolactone-induced hyperkalemia are more common compared to finerenone or eplerenone. And when we talk about blood pressure effect, again, it is much lesser with finerenone, so hypotension-like side effects are lesser. So indication-wise, spironolactone indicated for congestive heart failure and in case of resistant hypertension, eplerenone for heart failure and left ventricular ejection fraction, especially less than 40% or less than 30%. Even we can use eplerenone in resistant hypertension cases, especially when we are treating male patients. But for finerenone, the indication is chronic kidney disease associated with type 2 diabetes. So this pillar of therapy to reduce cardiorenal risk, we need to understand, because we need to provide our patient healthy life. So if we talk about different guidelines, which recommends a multifactorial approach to reduce the risk of diabetes complications. So ABC control, like A1C management, glycemic management, blood pressure management, and the C, cholesterol management or lipid management. On top of that, we need to use some agents now. The guidelines are giving clearly this message. If we use some agents which are already shown benefits in terms of cardiovascular or kidney outcome, then that always better for reduction in diabetes complication. So on top of lifestyle modification and diabetes education, we need to think about glycemic management, blood pressure management, lipid management, and agents with specific cardiovascular and renal benefit. If we talk about mineralocorticoid receptor antagonist now, which recommended along with other medications for cardiovascular and kidney protection, rather than as an alternative when other treatments have not been effective. It is not an alternative treatment. It is on top of the existing therapy like RAS blockade, like SGLT2 inhibitors. Then we are talking about non-steroidal mineralocorticoid receptor antagonists like finerenone. Because with RAS blockade, the renal trial, there is a good amount of residual risk. Even with RAS blockade and SGLT2 inhibitors, in credence, after DAPA CKD, after EMPA kidney, there is also 15% of relative risk. So we think more, and that more could be the non-steroidal mineralocorticoid receptor antagonist like finerenone. So that these three are the pillars of therapy to reduce the cardiorenal risk, and ultimately we can reduce the diabetic kidney disease and other complications if we use these three holistically. So holistic treatment approach of chronic kidney disease involves different pathways to slow the progression of heart and kidney disease. When we talk about RAS blockers, they will take care of hemodynamic perturbations. They decrease efferent arteriolar tone, hyperfiltration. They tackle the endothelial dysfunction and cardiac remodeling. When we talk about SGLT2 inhibitors, they help us in terms of, again, combating against hemodynamic perturbations and metabolic dysregulations. They increase the efferent arteriolar tone, modifying the tubulo-glomerular feedback, and anti-inflammatory, anti-fibrotic effects are there with SGLT2 inhibitors. They decrease the hyperfiltration, proteinuria, and oxidative stress. When we talk about GLP-1 RA, they decrease weight, dyslipidemia. There are certain studies, they decrease the oxidative stress and improve endothelial dysfunction. Mostly they tackle that metabolic dysregulation part. The SGLT2 inhibitors, not only metabolic dysregulation, but also the hemodynamic perturbations part. But when we talk about Finerenone, they decrease the inflammation, fibrosis, endothelial dysfunction, tissue remodeling, and proteinuria. And therefore, they are not only acting on hemodynamic perturbations, but also it has a huge influence on reducing the inflammation and fibrosis. So therefore, if we talk about this triad, the metabolic dysregulation, hemodynamic perturbations, inflammation, and fibrosis, the effect of Finerenone is robust on inflammation and fibrosis and hemodynamic perturbations part. So to summarize, individuals with diabetes are tenfold more likely to progress to end-stage renal disease than those without diabetes. Many patients may not reach end-stage renal disease because of premature death from cardiovascular disease. We had seen how from the very first 6 months of urine albumin-creatinine ratio increase, there is a gap in terms of cardiovascular outcome from those who are eGFR, whose urine albumin-creatinine ratio was less than 150, and compared to those whose urine albumin-creatinine ratio increased between 150 to 300, or even more than 300, there is a higher chance of having cardiovascular death or bad cardiovascular outcome. So early stage CKD management is often missed. If managed appropriately, its progression can be slowed or halted. Despite RAS blockade and SGLT2 inhibitors, patients are at risk of CKD progression. We had a good amount of residual risk. If we talk about MR overactivation, which contributes to inflammation and fibrosis, that is a potential treatment target to slow chronic kidney disease progression. And Finerenone improves cardiorenal outcomes by selectively targeting the mineralocorticoid receptor overactivation mediated inflammation and fibrosis in cardiorenal disease. So these are important take-home message why we should consider now Finerenone as an important tool to treat diabetic kidney disease. And another take-home message should be the screening of our type 2 diabetes patient. We should give more emphasis on calculation of eGFR, and number 2, the urine albumin-creatinine ratio estimation. And when we talk about urine albumin-creatinine ratio estimation, if one value is abnormal, we need to check 2 or 3 values within the span of 3 to 6 months. If those values are abnormal, then we can stamp the case as a raised urine albumin-creatinine ratio. Depending on the value, we can classify them according to the G criterias. And if it is more than 30 and between 300, there also the microalbuminuria, there also we need to take appropriate steps because our treatment goal should be prevention of diabetic kidney disease progression. So with that, I once again thank you all for hearing me. Thank you. Thank you very much.